In this video, we will discuss about respiratory auscultation. Whenever you keep steps to auscultate chest, what are the things you have to carefully observe and how to interpret that? All these things we will discuss in this video. So the first basic things are, ask the patient to breathe consistently through mouth. Then use the diaphragm of stethoscope and always auscultate in the comparative areas on either side. And what are the areas where you have to auscultate? Anteriorly, follow the mid-clavicular line till 5th intercostal space. Then laterally in the mid-axillary line till the 8th rib, you can auscultate. And posteriorly, mainly suprascapular area, interscapular area and infrascapular area, we will be auscultating. And remember, try to avoid the 2 to 3 centimeter area besides sternum or any midline structures during auscultation. So now we have instructed the patient to breathe properly and we have started auscultating and comparing all these respective areas. First we will understand what happens when they start taking breaths. So normally when patient breathes, the turbulence in the airways produces high frequency sounds. So when they start breathing, the passage of air, its turbulence in the airway will create some sound. And that sound which is generated in the airway will be passing through the lung parenchyma. So this entire structure it will be passing. And what happens is, in the lung parenchyma, it acts as a filter. That is, it will filter out the high frequency sounds and lets only low frequency sounds to travel across it. This is happening in the lung parenchyma, which is filled with healthy air-filled vesicles. So this point is very important. So whenever there is generation of breath sounds in the airways because of turbulence, it is traveling and getting filtered out of high frequency sounds. And we have kept the steth over the chest wall and we are auscultating there. So this filtered sound will reach the stethoscope. This is what we are hearing. And we know that inspiration is an active process, whereas expiration is just the passive recoil. Therefore, the lower turbulence of expiration will generate very low frequency sounds that our ears often cannot fully appreciate. That's why what happens is, the resulting breath sound when the individual is breathing normally will be vesicular breath sounds. Why is it named as vesicular? Because these vesicles are playing an important role in these sounds generation. It will appear just like the rustling of leaves. So it is an analogy. The rustling of leaves kind of sound will be heard when the individual is normally breathing. This is in the normal individual. Now we will understand what does vesicular breath sound actually mean. So here, when the individual is taking inspiration and because of the turbulence, whatever sound is generated will be heard over the chest piece. And as mentioned, expiration is the passive process. So the turbulence will be low. So the entire expiration might not be heard to our ear. That's why if you observe the ratio, when you are auscultating, inspiration might appear longer, whereas expiration might be very short. So generally we say it as 3:1 ratio. And the intensity will be normal. And quality we have already described, it will be just like rustling of leaves. And if you have focused here, there is no gap between inspiration and expiration. And the major reason for this type of sounds will be the vesicular phase. That is, the vesicular part is filtering out the high frequency sounds. And that is the reason for vesicular breath sounds. The other type of breath sounds are called as bronchial breath sounds. So as the name indicates, these sounds are just like the sound which is heard over the bronchus or main airways. So here, if you compare with vesicular sounds, the inspiration phase and expiration phase will be equal. Sometimes even the expiration might be quite longer than inspiration and the intensity will be loud compared to vesicular breath sounds. And what type of quality will be there? It will be aspiring or blowing quality, we can say. Hollow it will be. And there will be presence of gap between inspiration and expiration. Why is it happening? Because there is loss of vesicular phase. So this vesicular phase, whatever filtration was happening, that is lost. That's why all these sounds are louder. Actually, there is one more variant of breath sounds we can consider, that is bronchovesicular. So what does it mean? It is a type of breath sound which is intermediate between bronchial and vesicular in character. That is, inspiration and expiration will be almost equal, but there is no gap. So it is a mixture of both of these features, which is normally heard over upper interscapular and suprascapular areas. In bronchial breath sounds, why that vesicular phase is lost? So you'll understand that, as I mentioned, there will be loss of attenuation, that is vesicular phase will be lost. So what is the mechanism? If you observe here, the airways and the lung parenchyma, mainly the air-filled vesicles, and we have mentioned that the sound which is generated will be traveling all this way. But to generate bronchial breath sounds, vesicular phase is lost. That's why whatever the high frequency sounds are, they are not being filtered out. So we are able to hear that loud intensity sounds, which we call them as bronchial breath sounds. Now why this vesicular phase is lost? Because there might be solidification of these vesicles, or these vesicles might have collapsed, but the bronchus is still patent. So this solidification or loss of this vesicle will lead to direct transmission of these high frequency sounds without any filtration, leading to higher intensity. So what might be the pathologies for bronchial breath sounds? It is consolidation or collapse with patent bronchus, or there might be presence of cavity. So these vesicles have lost their structures and have become cavitatory lesions. In a way, these vesicles are not there. That's why there is no filtering out. This is the reason for bronchial breath sounds. Now, in the same travel path, there might be some other factors which might further attenuate the sounds, leading to excessive filtration and reduced intensity of breath sounds. That we will see it here. For example, if there is excess air, hyperinflated lung, we know that air is not a good conductor of sound, leading to further attenuation. Normally there will be air, but if it is in excess, for example in emphysema or pneumothorax, in that case, this excessive air media will further attenuate the breath sounds, leading to reduced intensity of breath sounds. Or if there is presence of another intervening media, that is fluid or blood or even pus, between these structures and the auscultating area over chest wall. So if anything is intervening and which is attenuating the sound, for example in case of pleural effusion, hydropneumothorax, there might be further attenuation of the sounds, leading to reduced intensity of breath sounds. So hope you have understood it. Vesicles will be normally filtering out, leading to normal vesicular breath sounds. If these vesicles are not doing their action because of some pathology, there will be direct transmission of high frequency sounds, leading to higher intensity of breath sounds, which we call it as bronchial breath sounds. And the conditions are consolidation, cavity and all. Otherwise, sometimes there will be excessive filtration of these sounds because of excess air media or excessive fluid media in between, leading to attenuation of breath sounds, causing decreased intensity of breath sounds. Once we have understood these mechanisms, bronchial breath sounds are further subdivided into tubular, cavernous and amphoric. So what does it mean? In tubular, the vesicles will be consolidated. This is consolidated usually, and these tube-like structures, whatever the airways are there, those are directly getting transmitted. That's why it is named as tubular, and it will be high-pitched sounds, just resembles tracheal breathing. If you keep your steth over trachea, whatever the nature of sound you will hear, that is similar to tubular breath sounds, and it is seen in consolidation and collapse with patent bronchus. The other variant of bronchial breath sound is called as cavernous. Here again the vesicle part is facing some issue. So what has happened there? There is a cavity and it is thick walled cavity. So whatever the sound is producing and traveling here is getting resonation. So it will be hollow and low pitched because of the resonation of the sound, leading to cavernous, a type of hollow high intensity breath sounds. The other variant is amphoric, where again the vesicles are damaged and have formed cavity, but it is quite superficial and thin walled cavity. So how will be the sounds? They will be high pitched. There will be metallic sound if you hear it, just like blowing through the top of bottle. So whatever that metallic sound will be there, that is typical of amphoric breath sounds, and it is seen in large cavities as well as in bronchopleural fistula. Now we have understood regarding the intensity and type of breath sounds. So you have focused upon these 2 points, intensity and type of breath sounds, in all these areas. Now, instead of just breathing, you just ask the individual to say some words. Commonly, ask them to say 1, 1, 1 or 99, 99 like that. So what we are doing here, instead of generation of the breath sounds, we are trying to hear for voice sounds. That is called as vocal resonance. So the vocal cords will generate some sound and it will travel through the same path, that is airways, lung parenchyma, and we are auscultating it over chest wall. This is what we are doing in vocal resonance examination. Again, whatever the sounds are generated here will be filtered and attenuated at the lung parenchyma. So after this filtration only we are hearing the sounds. So the same mechanisms will apply here as well. If there are any intervening structures which are further filtering these sounds, it will lead to reduced vocal resonance. What are the examples? Same, like pleural effusion, emphysema, pneumothorax and all, and collapse without patent bronchus. And these sounds will be heard with increased intensity because there is some issue with the filtration at vesicles. Again the same mechanisms, that is consolidation, a collapse with patent bronchus, or even at the level just above the effusion, we can see increased transmission of these sounds which are generated at vocal cords, traveled through the airway but not filtered at vesicles and are getting directly transmitted to the chest wall. So in these conditions, vocal resonance will be increased. It is almost similar to the one which we have discussed previously. Instead of breath sounds, we are focusing upon the voice sounds. Just like the further classification of bronchial breath sounds, whenever you hear increased intensity of these sounds, always look for some other parameters like bronchophony, whispering pectoralic and egophony. What does it mean? Normally, when we keep step and auscultate and when we ask the individual to say some words, that is vocal resonance, whatever the sound which we will hear will appear as if it is being generated at the chest piece. Whereas in bronchophony, when there is increased amplified transmission of these sounds, the same generated sound will appear as if it is being generated in the earpiece of stethoscope. So it will be quite more closer to the ear. That is, spoken words are heard directly and clearly into the earpiece of steth. Otherwise, normally words will be quite muffled as if spoken directly into the chest piece. This point is very important to understand. In normal individuals, if we auscultate, it will appear as if the sound is getting generated in the chest piece. Whereas in case of bronchophony, it will be as if it is being generated in the earpiece itself. That is bronchophony. What about whispering pectoralic? We should ask the individual to whisper the same words again, and it will be better appreciated with more clarity in case of whispering pectoralic. Why is it happening? Because of better transmission of amplified higher frequency sounds. That's it. These higher frequency sounds, whatever are being generated, will be transmitted better without any filtration. That's why we are getting these high intensity sounds. So these two are related to the increase in the quantity, that is intensity. One more similar thing is regarding the quality of voice sounds, that is egophony, where we will ask the individual to say E and it will be heard as A. So it is nothing but pitch alteration, where we ask the individual to say E and it is heard as A. Just like bleating of a goat. Don't get confused here. Many students will think we have to instruct to say A and it will be heard as E. But remember, it is quite reverse. Whatever we write as egophony, you just reverse these letters. Ask them to say E, it will be heard as A. So once the intensity of breath sounds is being focused, the type of breath sound is being noticed, and we have examined for vocal resonance as well. Then focus upon the presence of any adventitious sounds. And here, remember, few of the terminologies like rails, crepitations, even V's are outdated according to some textbooks. Now just prefer only two terms, that is crackles and Rhonchi. Even today, many of us will still use crepitations, rails and all. No problem in that, but the exact understanding of these terminologies is very important, because V's is very commonly used even nowadays. But remember, V's is often heard from a distance. It is not an auscultatory finding. That's why they are insisting to use the terminologies like Rhonchi and crackles. Now, what is the difference between Rhonchi and crackles? First of all, if we focus on Rhonchi, it will be a musical sound, that whistling kind of sound you might have heard. That is musical in nature, and it will be quite continuous and of quite longer duration, about 80 milliseconds. And why does it happen? Because of the airway narrowing. So these airways will be narrowed at some point, where the passage of air at this narrow space is creating a sound that is called as Rhonchi, and it is musical in quality. And we know that this airway narrowing will not be altered upon coughing. So these sounds, Rhonchi, usually will not alter with coughing. And it is further subdivided into fixed monophonic and widespread polyphonic Rhonchi. What does it mean? Monophonic, a single musical note will be heard at a fixed localized point. So when does it happen? If there is airway narrowing because of some compression by a tumor or foreign body obstruction, in that case, at only that particular point, we will be able to hear one type of musical note, that is called as monophonic. Whereas if the airway narrowing is widespread and diffuse, we might hear multiple musical notes, that is polyphonic Rhonchi, commonly seen in COPD, asthma cases, even pulmonary edema. When it comes to the crackles, these are non-musical, and these will be explosive and bubbling in quality, and these are non-continuous and lasting for very short duration, 10 to 20 milliseconds we can say. Why does it happen, crackles? When the air passes through secretions. For example, if you take some water in a bowl and if you try to blow through it, you will hear that bubbling sound. The same mechanism is happening in our respiratory system as well. Normal breathing air is passing through some secretions, leading to that bubbling kind of sound. Or the other mechanism might be due to sudden opening up of the closed airways. You might have seen this opening up of a crumpled tissue paper. Whatever that sound you will hear, right? Just like that, crackles will be there. So just remember, blowing through the water, that bubbling sound, and opening up of a crumpled tissue paper, that is what crackles will be heard as. And again, if you see here the relation with coughing, upon coughing there might be some alteration in the secretions, leading to change in the nature of crackles. So definitely this might get altered upon coughing. This point is one of the differentiating factor between these two. And crackles are further subdivided into fine and coarse crackles. So what are these fine crackles? These will be usually soft but lasting for very short duration, that is less than 10 milliseconds. If you rub your hair between your fingers near your ear, whatever the sound will be there, that is typical of fine crackles. And what is the mechanism for this fine nature? Air is passing through thin secretions in the alveoli. So the secretions are quite thin. Where do we see that? In pulmonary edema, early stage of pneumonia, and the other reason might be fibrosing alveolitis, where actually because of the sudden opening up of the closed airways, that opening up of crumpled tissue paper, what I have mentioned, is the mechanism in fibrosing alveolitis. And many a times they label it as Velcro crackles or crepitations. If you strip away the Velcro, whatever the sound is heard, that is typical of fibrosing alveolitis. Coming to the coarse crackles, these are quite louder, again non-musical, non-continuous, bubbling kind of sounds, and when we compare it with fine crackles, these are quite long lasting, that is about 20 milliseconds, but not to the extent of Rhonchi, which will be very longer, that is about 80 milliseconds. And The analogy is bubbling, explosive kind of sounds. Why does it happen? When air passes through the thick secretions in airway, alveoli, or even cavity, this sound will be heard. So what are those thick secretions? It can be due to bronchopneumonia involving airway, alveoli, even bronchitis, bronchiectasis, and cavitatory lesions where there is collection of some secretion in the cavity, and when air passes through that, we will hear coarse crackles. But whenever we get these adventitious sounds, always try to match with the timing of respiration and always try to look for the relation with coughing. That is, if these sounds are early inspiratory, it might be due to the larger airways like chronic bronchitis. And if it is mid inspiratory crackles, it can be pointing towards bronchiectasis or even cavitatory disease. Mainly in bronchiectasis, we describe it as coarse leathery crackles, which is again a hallmark feature of bronchiectasis. Suppose these adventitious sounds are late inspiratory. This is when the air reaches almost alveoli. So think of some alveolar pathologies like pulmonary edema or fibrosing alveolitis, where I have mentioned that it will be velcro kind of sound. And regarding relation to the cough, if we ask the individual to cough and auscultate again, there might be some changes if it is due to crackles and secretions mainly. Whereas if it is due to airway narrowing, the rhonchi, it will not alter with coughing. And remember, if there is post-tussive crackles or post-tussive suction kind of sound, it is very typical of a cavitatory disease. Another adventitious sound during auscultation is about pleural rub. So mainly the areas of maximum expansion of the lung, that is infraaxillary or infrascapular areas, there if the pleural layers are inflamed, we might hear this pleural rub. So it is generated because of the movement of these inflamed layers of pleura. How will be the character? It is quite superficial and coarse scratching kind of sound will be there, and it is present on both phases of respiration, inspiration as well as expiration. And this sound will not alter with coughing, but it might get intensified by applying pressure with the diaphragm of stethoscope and usually associated with pleuritic pain. So these are some typical characters of pleural rub. What are the common causes of this inflammation of pleural layers? Viral pleuritis. And finally, just remember that the intensity and quality of all breath sounds are so variable from patient to patient and in different clinical situations that conceptual knowledge is only the foundation. It is strictly through repeated hands-on auscultation of many different chests that a clinician becomes familiar with normal physiological variations. That is, to master this auscultation, we need to repeatedly auscultate over many patients. So with the experience, we will be able to become better at finding out the abnormalities. That's why we say the ear must be trained through experience. So this was all about auscultation of a respiratory case. So next time, whenever you keep steth, always focus upon the intensity of breath sound, the type of breath sound, and instruct the individual to say some words and look for the vocal resonance, whether it is increased or normal or reduced. And the other terminologies like bronchophony, egophony, whispering pectoralici should be well known. Then regarding adventitious sounds, first try to differentiate whether it is a rhonchi, crackles or pleural rub. Once you have decided that, focus further to subdivide again into various monophonic or polyphonic, fine crackles or coarse crackles and all, and try to relate it with the timing of respiratory cycle and ask the individual to cough and look for the change in the nature of these adventitious sounds, which will again hint us towards numerous pathologies. Hope you have understood it very well. Please share it among all the undergraduate students for better understanding of one of the important segment of respiratory examination, that is auscultation. Thank you so much.